Hello and welcome to our next session. So today we're going to look at some airway management, and I have Bill here who's our subject for today, and what we're going to do is we'll go through a stepwise approach for airway management. So our first concern is to check whether the patient has an airway, and we could have a quick look in the mouth to make sure that is clear, and then normally in order to open the airway we would use the head tilt chin lift method. So that's one hand on the forehead and the other couple of fingers on the bony bit of the chin. Don't press too far into the soft tissue because that can cause trauma and further aggravate the airway. So on the bone and then tip the head back, and that will naturally make the jaw drop open. So now this should provide a good airway. If this patient has suffered from some sort of trauma, like a fall or a motor vehicle collision, and we suspect that they might have a C-spine injury, either due to the mechanism or the fact they're complaining of neck pain, we obviously don't want to hyperextend the neck like that. So if we put Bill back in a neutral position, what we can do is we can do the jaw thrust. And the jaw thrust is you put your fingers under the angle of the jaw, and then support on the maxilla, on the cheekbones, and then you lift the jaw forward, and that again will open the airway without hyperextending the neck. So if we go back to our head tilt chin lift, get him back into that position, we now have some additional adjuncts we can use to support the airway. Again, we can use a stepwise approach, so we use simple ones and then go on to more complicated ones. So if we have a look at some oral pharyngeal airways, I have some here. They come in various sizes, as you can see. There we go, right down to children's and ones for infants as well. So in order to size the airway, what you need to do is, if you imagine where this airway is going to go, it's going to sit by your teeth and it's going to go down the back of your throat. So if we just try this one just for demonstration purposes, and if I put that there, obviously it's not even getting past the jaw, whereas a very big one would go right past the jaw, so we need to find somewhere in between. So if I try that one, for instance, you can see it fits nicely around the angle of the jaw and sits next to the incisors. So this is the correct one for this patient. To insert the oropharyngeal airway, we always insert it upside down, so as illustrated. We'll pop it into the mouth, rotate it, and then locate it. And then it will sit just on the incisors and provide a nice clear airway down the back of the throat. So that's the oral pharyngeal airway, or OPA. So we have some different types of airways. The next one we're going to look at is the nasal pharyngeal airway. So I have some examples, various sizes here. That's an 8, so that's a very big one. So it's a 9, it's a very big one. That's an 8, that's still quite big. And this one is a 7, so this is a reasonable size one. These go up your nose. Inside your nose you have a number of structures called tubercles, and when you try and insert the NPA, sometimes these can be obstructed by the tubercles, so that can cause problems. So in order to insert it, we place it around the nares, the entrance to the nostrils, and we rotate it slightly as we insert it into the patient. And this will help it pass through the nasal pharyngeal space. So you can see it goes in quite a long way. If I was going to measure this airway, if I just take this out a second, again we think about the exterior anatomy compared to the interior anatomy, and we have the opening and we have the back of the throat. So we laid one against the other, and you can see that this one will more than fit this patient. Actually, what we need to do is measure it from the nares to the tragus of the ears. So this one is actually a little bit long, but you can see for illustration purposes. So that's two sorts of airway. The third sort of airway we're going to look at today is your eye gels. So again, these come in different sizes. I have 3 sizes here, and they're based upon weight. So the smaller one is for 30 to 60 kilos. The larger one is for 90 plus kilos, and the one that fits most people is most adults is the 50 to 90 kilo variety. You should aim to put in the largest airway you can fit that will comfortably fit the patient. The eye gels are particularly important, and they're very clever in their own design because the mouthpiece or the throat piece actually changes shape with heat. So the heat of the body will help mould that to fit the back of the airway. So these are, if I do the head tilt chin lift again, and these simply slide down the throat. What I'll do for this one is I'll use a smaller one just for illustration purposes, because he hasn't got a very big mouth. Okay, so this one slides down the throat. And it's quite a difficult airway to sight, so we're going to use some lubrication to make it slip down more easily. So just pop that there a second. Excuse me while I get some lubrication. So you normally use something like a water-based gel, but for this instance we're going to use some alcohol gel, and I'll just sterilise the dummy while we're doing it. So you place the lubricating gel on the cradle, and then you rub the back and the sides of the airway over the gel, and that should slip down nice and easily now. There we go, it's much better. Yeah, if you can see, there's a red line on this airway, and that should come to rest at the teeth. So that if I attach this now to a bag valve and mask, and if I squeeze that, you can see the lungs inflate, and we know we have a good airway. So while we have the patient with the BVM in situ, if we had to support somebody's respirations, we'll be aiming to ventilate them at a rate of 10 to 12 per minute, approximately 1 every 5 to 6 seconds. You don't need to overinflate them, and that'll give them sufficient oxygen for bodily purposes. What we're aiming to do is just raise the chest so we can see the lungs are inflated. So you don't need to give it a big squeeze because that'll be far too much. You just need to give it a little squeeze, just enough to raise the lungs. Okay. Take that for a second. I'll just remove this airway, same way as it came in, just slips up the throat again and to one side. So those are 3 basic airway manoeuvres. Again, if we don't have an airway in situ, we can get the BVM. Placed over the casualty's mouth. This is now recommended as a 2-person technique. So one person would hold the mask in situ and the other person would squeeze the bag. However, anaesthetists that use something like called the anaesthetist grip or the C grip, where they place their hand around the neck of the bag valve and mask and curl their fingers round supporting the head, and it is possible to ventilate the patient this way, although it is not a gold standard technique. As you can see, it works okay. Okay. So other considerations is about oxygenation. Anytime you're performing any sort of airway manoeuvre with a patient, if it's unsuccessful or you have trouble getting that airway in, it's best to stop, re-oxygenate the patient and then carry on. So we might re-oxygenate it using a bag valve and mask attached to high flow oxygen, or we might use some sort of oxygen mask, such as a simple mask or a non-rebreather mask, just to top up that patient's oxygen. The only other thing we have to consider is suction, and if a patient has some sort of foreign matter in their airway, such as fluid or vomit, we might use something like a Yanker suction to suction the airway out. We would not suction for more than 10 seconds, and we always apply suction as we're pulling the suction catheter out of the mouth in order to not cause any vagus stimulation. Okay, that's all I need to cover today with this airway management session. So I thank you for your time and say goodbye.